Simpson. He'll be speaking on preimplantation genetic diagnosis for chromosomal and single gene disorders. Dr. Simpson is the Senior Vice President for Research and Global Programs at the March of Dimes and President of the International Federation of Fertility Societies. He's also a past President of the American College of Medical Genetics. Dr. Simpson.
Thank you very much, Dr. Watson. It's a pleasure and a privilege to be able to contribute to this webinar series. Our topic today is preimplantation genetic diagnosis, as noted. Now, this is a specific form of prenatal genetic diagnosis that is uncommon, but has a unique place and often is the only applicable prenatal diagnostic approach. In this particular presentation, we will discuss first how and when we can obtain DNA prior to implantation, which occurs 6 days after fertilization. We will discuss when preimplantation genetic diagnosis is applicable and when other prenatal diagnostic approaches are much more practical or preferred. And finally, if we do decide to implement pre-implantation genetic diagnosis, what pitfalls exist of which we need to be aware. Now, timing. We're all aware from other webinar series and our knowledge that exists that there are multiple stages in gestation in which we can obtain samples. Amniocentesis historically is done about 15 to 20 weeks. Chorionic villus sampling represented the first trimester approach, typically at 10 to 13 weeks. And now we're talking about days prior to implantation. So we can start with the polar body before fertilization even occurs, and we have available the option of up to 6 days at which time implantation occurs. This requires assisted reproductive technologies, typically for couples who are infertile, and this is their only option for achieving their own pregnancy. One approaches assisted reproductive technologies by stimulating the ovary to produce more follicles and hence more oocytes than ordinarily would be the case in a given cycle. This particular slide shows 2 ovaries in which there are black circular areas in each of these ovaries. These contain follicles, and the physician involved would aspirate each of these and from that obtain an oocyte. Fertilization could occur in vitro in the petri dish, and after that one would have the option of obtaining samples that we could use for a PGD. For example, this is a polar body. We can see the male and female pronucleus for this very one-stage embryo about to fuse. The embryo is held within the zona pellucida, which has been broached at the top of the screen at about 1 o'clock by a catheter, and one of the 2 polar bodies is about to be removed. The fact that there are 2 polar bodies indicates that fertilization has occurred, and that is important in a specific situation that I'll mention in just a minute. We can also wait a few days, and by 3 to 4 days we have a cleavage stage embryo. One can see now multiple stages, multiple cells, typically about 8 at this stage. Again, one traverses the zona pellucida, and you can see within the catheter a single cell that's been aspirated and will be used for diagnosis. More commonly these days, we wait until about 5 to 6 days, at which time there are a little over 100 cells, and we can diagnose the trovectoderm, which we can make a diagnosis based upon the trovectoderm biopsy. And this is shown toward the bottom of the slide at around 5 o'clock to 8 o'clock. This will eventually develop into the placenta. An advantage occurs here that one would not remove any of the cells that will contribute to the inner cell mass or eventually to the embryo. So several different options that would exist here. Now, what are the indications? One obvious indication exists for couples who wish to avoid a clinical termination of an affected case. The most common approach that is used for these individuals is to do a cleavage stage biopsy at 3 days in order to obtain the single blastomere that we illustrated previously, or conversely wait until 5 to 6 days in which we have a blastocyst and can do a trophectoderm biopsy. Some individuals and some countries will preclude any form of pre-implantation genetic diagnosis or sometimes prenatal diagnosis whenever there is danger of an affected fetus and termination. In these situations, one can still analyze the first polar body because fertilization has not yet occurred and is as manifested by lack of a second polar body. So this has a limited but attractive in certain cases approach. There are other indications that are just totally impractical, although in theory they could be applied for PGD. It's obvious whether or not one does a prenatal screening for aneuploidy or directly moves to an invasive procedure, that the likelihood of a pregnancy being affected with aneuploidy is low, and therefore this would be an inefficient and very expensive approach. But in theory, one could apply. There are a number of circumstances in which PGD is one approach and traditional prenatal genetic diagnosis another approach, and certain situations in which, again, either could be done, but there's good reason to believe that PGD is the most applicable approach. So let's spend most of our time talking about this. So for those conditions in which continuing discussion exists concerning the preferable approach, exists for couples in which one of the individuals has a balanced translocation and is at increased risk for unbalanced embryos and hence children with congenital anomalies. The other exists for single gene disorders in which we're well aware the risk is historically 25 or 50%, depending upon the mode of transmission. But there are a number of circumstances in which, unfortunately, more than a single genetic disorder is segregating in a given family. In these situations, very high risk, traditionally 60 or more percent, exists, and hence it becomes very attractive given the disadvantage of having multiple clinical terminations. So in translocations, normal embryos are of course the goal, and this is less easy to achieve than exists in even the normal pregnancy. The reason is that the segregants are frequently unbalanced. In reciprocal translocations, it develops that there's only about 20 to 30% transferable embryos. In Robertsonian translocations, those involve chromosomes 13, 14, 15, 21, and 22, the odds are a little bit better, but still no greater than about 40%. And in fact, in many of these couples, the clinical manifestation of the balanced translocation in one or the other partner is actually subfertility. It can often be multiple miscarriages, and in fact, it's uncommonly that of an infant who has a congenital anomaly. So in these circumstances, we are looking at the odds of finding a normal embryo, transferring that back, and in doing so, achieving a pregnancy. We historically did that by fluorescent in situ hybridization for chromosome-specific or region-specific probes. So here we have a balanced translocation between chromosomes 5 and 13. And one can simply take advantage of existing technology, probes that exist. And here we see at the top a probe for the short arm of chromosome number 5 in green. Toward the bottom of this same normal number 5 chromosome, a second locus for EGR1, in orange. We can also pick out a probe on the other chromosome that is involved in this translocation, namely the retinoblastoma probe on the far right as shown. So by looking at the number of probes that exist, we would of course expect 2 each for these probes, and one can take advantage of this and determine whether the chromosomes are normal or not. Since one can also look at the proximity of 2 given probes to one another, we can also make a decision about whether or not the embryo is balanced for the translocation or genetically normal. However, fluorescent in situ hybridization is not necessarily a simple analytical procedure to perform, and increasingly the technology has moved to array comparative genome hybridization, which is covered in another lecture in this webinar series. This allows all chromosomes to be assessed. However, it has the disadvantage of being unable to distinguish between a balanced carrier and a genetically normal embryo. I will not go over in detail comparative genome hybridization because it's done elsewhere, but the basic issue we recall is that we can label the sample DNA, patient's DNA in this slide, and hybridize that with the reference DNA, green in this particular slide. And if the patient's DNA has a normal chromosomal constitution, mixing red and green naturally gives us yellow. And so that would indicate that there's no deletion or deficiency of that particular sample. If by contrast in this example, a particular region of a chromosome or an entire chromosome is relatively more green than red, it indicates that there's a deficiency or a deletion of the patient's DNA. The converse would produce a red signal in this case, and these can be indicated with their location using platforms that are used in arrays that have been discussed elsewhere in this particular series. This typically appears in a sample like this. One can look at each of the chromosomes and see if there is an equal amount of the reference and the sample DNA as shown by the color. And so if that is the case, we would see an isobar that you see all the way until you get to chromosome number 16 when you see suddenly a deficiency of the patient DNA. If we were to do PGD for couples who have balanced translocations, this slide shows the advantages. We can avoid multiple miscarriages, which we know will occur. And in fact, the frequency of miscarriages in couples who undergo PGD in this circumstance is less than 15%. Much more importantly, I think, and worth recalling, is that we can achieve live birth much more rapidly, and this may be pivotal, particularly for older couples. This slide shows us that in general the outcome of couples with balanced translocations is favorable. We can see the cumulative live birth rate in 3 different series approximating 70%. The problem, however, is the length of the time to become pregnant. We typically expect pregnancy to occur within 1 year of attempting to do so. Otherwise, that's the definition of infertility. You can see in 2 series here that the mean time in order to achieve that 70% was 6 and 4 years respectively. Now, if one is 25 years of age, there's typically years of fertility in which this can be achieved. But if the patient is 38, 39, 40 years of age, there may not be 4 to 6 years of available fertility to occur. And it's for this reason that the American Society of Reproductive Medicine has recommended PGD given the time to achieve pregnancy naturally. Now, the area that we've been discussing, array CGH and preimplantation genetic diagnosis for translocations, can of course also be applied for numerical changes, namely aneuploidy. So we previously discussed the option of doing this as an alternative to CVS, and in certain groups it may be important to have a diagnosis prior to 40 days embryonic life, and that's earlier than one can safely perform for CVS. So for these couples, this becomes an attractive option despite the inefficiency. We've mentioned decreasing miscarriages, and the third is increasing the live birth pregnancy rate in assisted reproductive technology. Now, increasing the live birth rate is a very reasonable option. We are quite aware that there's a very high frequency of aneuploidy, even in morphologically normal embryos, and so the clear strategy would be to transfer only euploid embryos based upon FISH or array CGH. And indeed, if we look at perhaps the major culprit in women of advanced age not being able to achieve pregnancy with assisted reproductive technology, it's because of miscarriage. Here we can see from United States data collected by the Centers for Disease Control the increasing rate of miscarriage in ART pregnancies, especially after the age of about 40. So you can see that almost 60%, over 60% of couples who do become pregnant with ART at age 44, and that's a low number in and of itself, will actually, unfortunately, then have a miscarriage. And this explains this reduced pregnancy rates in ART. This is the mirror image of the other slide that I just showed you, for example, explaining the quite low pregnancy rate, less than 5% in couples at 44 and beyond. So this approach was naturally applied once FISH became available in the 1990s, and certain centers had very good results, so it appeared. But none of these were able to conduct randomized clinical trials. These trials became possible, particularly in Europe, in centers that were initiating this technology, and they surprisingly did not show benefit. There have been concerns raised about this, mainly the optimal method of analysis and some of the non-standard indications, but nonetheless, that was the approach, and for many years there was no further increase in PGD aneuploidy testing for this reason. Here are the traditional explanations for the non-beneficial effects. The women were too young. There were too few testable embryos to warrant the damage that could be occurred by an embryo biopsy, which appears to be about a 10% loss in likelihood of pregnancy rates in and of itself. So one needs to overcome that the deleterious effects of embryo damage with the benefit of transferring only normal embryos. And in certain circumstances, there was suboptimal technology, specifically failure to know the constitution of every chromosome. That's all changed literally within the last 2 years for two reasons. Number one, array CGH is used universally in PGD for aneuploidy testing, and it's preferable for fluorescent in situ hybridization for reasons mentioned. Secondly, trophectoderm from biopsy for the blastocyst is performed. This traditionally appears to be easier, particularly in labs just initiating this procedure. So here are two randomized clinical trials from two established centers using blastocyst transfer, in which in one case array CGH was utilized and only chromosomally normal embryos were transferred. The second, in which there was only morphology. You can see the clear differences 60+% versus about 40% when array CGH is used. A second consideration that is going to speed the introduction of this technology universally, in my opinion, is the fact that we can use this to diminish increased frequency of multiple gestations, which we all know is a problem with assisted reproductive technology. So here's a study toward the end of 2000, relatively recently, in which the randomized trial consisted of a single embryo transfer, blastocyst, subjected to array CGH with only a chromosomally normal embryo transferred, versus 2 embryos that were transferred, assessed by morphology only. You can see that the pregnancy rate is very impressive in both groups, 60 or 65%, and the impressive factor in terms of pregnancy complications, healthcare costs, is that the twin rate was 53% without array CGH, but 0 in this series once array CGH and single embryo was transferred. So I think we're going to see increasing push in the ART community for PGD for this reason alone. So with scale biopsy and array CGH, we will see increasing pregnancy rates. And this can be applied using a variety of technologies, such as achieving multiple blastocysts, biopsying them, freezing all except one, and then a single embryo per transfer would be done in the future. And I don't need to tell you that this would reduce preterm birth and healthcare costs. So let's move next to single gene PGD. This can be achieved whenever we know the locus for a single gene disorder. We do not even have to know the specific nucleotide perturbation in a given family or a given case, as long as we know the locus. This becomes an option, of course, in any pregnancy, but it becomes pivotal in certain situations in which it becomes very unlikely that we would be able to achieve our goal without PGD. So here are 2 unique indications for PGD. One is non-disclosure of results. For example, say that we had a prospective parent who has themselves a parent, that is the grandparent of what we hope to be the embryo, and this individual has a heritable genetic disorder such as Huntington's disease. Our patient does not wish to know whether they have inherited this deleterious phenotype, but they still wish to avoid transmitting the mutation to their own offspring. We can only achieve that by doing PGD, looking at the multiple embryos, allowing the provider to transfer back only the genetically normal, resulting in a favorable pregnancy, but at the same time, our patient never knows whether they have or have not inherited that particular genotype. We've mentioned previously 2 different conditions, and the third situation is the need for HLA-compatible embryos. So this is a circumstance in which a genetically abnormal fetus, a genetically abnormal infant has occurred. The most common conditions are beta thalassemia and Fanconi's anemia. Here we have non-functioning bone marrow in many circumstances to a greater or lesser extent. And this can be lethal, and we won't go into the specific clinical characteristics, but very often we are confronted by couples who have an older affected case. They now wish to have a pregnancy without that genetic disorder and wonder whether or not the umbilical cord stem cells, which are collected routinely in many circumstances, could actually be used to cure the bone marrow problem in their older sibling who could be moribund by this stage. This works fairly well if you have an HLA match between the cord blood that it will be used for the bone marrow transplant as well as the recipient. Over 90% success rate. The success rate is considerably diminished, about 60%, if non-HLA matched stem cells are utilized. It becomes impractical to expect the genetically normal embryo to also be HLA compatible simply on statistical terms. So the likelihood that the older sibling and the younger fetus will both be HLA compatible is 1 in 4. The likelihood that we have a genetically normal situation for an autosomal recessive trait is 3 in 4, both heterozygous as well as homozygously normal. So the overall likelihood of achieving success is 3 in 16. So that would be a daunting possibility with natural conception, requiring multiple terminations. However, if one tests both for HLA as well as for the genetic disorder and looks at multiple embryos, the chances of finding 1 or 2 embryos that are both genetically normal and HLA compatible is quite reasonable, and hence the success of this particular approach. Now, if you look at large centers such as Reproductive Genetics in Chicago that have been doing this methodology for years and years, you find very low diagnostic rates. Not zero, of course, but this is a multiple decade assessment for this particular center, which is one of the first that did this and still has one of the largest greatest experience in the world, having studied over 250 cases. So in this situation, you can see very few diagnostic errors based upon live births and pregnancy samples. One can achieve that despite the fact that if we're dealing with a single cell, there's only 6 picograms of DNA. So obviously, we have to amplify this DNA using polymerase chain reaction, and amplification is never 100% efficient, no matter what technology one uses in order to amplify sufficient DNA to arrive at a diagnosis. So a phenomena called allele dropout occurs, meaning simply that the DNA that one desires has unfortunately not been amplified, and therefore this poses problems in a diagnostic sense. Here are some of the explanations for allele dropout that can occur. One is simply bad luck, stochastic failure of the probe to find its way for hybridization. The second is double-stranded breakage. And the third is the fact that actually allele dropout has not occurred, but one allele is simply amplified to such a greater extent than the other that the phenomena appears to be allele dropout. So what is the solution for allele dropout, and is it a concern? So this simply shows a schematic diagram of an individual who is heterozygous, a cell that is heterozygous. There's one mutant allele shown by the bar colored in from the red allele, and then there's a normal allele on the right. So we expect both alleles to amplify. So in the bottom row, we can see signals indicating that, in fact, both of the DNAs that we are interested in, the mutation as well as the normal, have been amplified. We can then see what happens if only the mutant allele is amplified in the middle of these drawings, meaning that there's dropout for the normal allele. And finally, what happens if the normal allele has been amplified but not the mutant allele? In this situation, we have a dropout of the normal allele. So the dropout of the mutant allele. So in this situation, we have these various possibilities. Some pose clinical problems and others do not. We won't go into all of the permutations that exist, but consider what happens if we have a mutant autosomal dominant disorder and there's failure for that amplification to occur for that allele. The obvious results would be we appear to have a false negative diagnosis. If we transfer that embryo, we would create a situation in which we would have an abnormal offspring or embryo and would have failed to recognize that because of the allele dropout. So how do we address this? The way we address this is to determine the status of the embryo or the cell, not simply on the basis only of the mutation itself, but linked markers on either side of the mutation. So this allows us to detect the allele status of the entire chromosome or the entire chromosome region, even if allele dropout occurs. So this particular slide illustrates a strategy that we would use in linked markers that can assess whether the embryo is normal, even if we have no information about the mutation itself. So here is a family in which the X-linked recessive disorder hydrocephaly was segregating. It's due in this family to a miscarriage mutation. The grandmother of the index case that brought this family to the geneticist's attention had herself had a child with hydrocephaly. The mother, that is the mother of the index case, had obviously had an affected child who is deceased and for which DNA was not present. So we clearly have two individuals who are obligate heterozygotes, the grandmother, who is A, the mother, who is marked C in this particular slide. Now, without knowing exactly which linked markers are associated with the mutation on a given chromosome, we can deduce that by looking at the genotypes and the markers that exist on the grandmother as well as the mother. So if you look at both of those, ignoring the color for the time being, you can go back and deduce what the markers were on the chromosome from the grandmother, A, that had to be transmitted to the mother of the index case, C, because that's the only way that that particular set of markers could have arisen, because some of these were not present in the husband of the A, the grandmother here. So we now have a set of red markers that connote the status of the chromosome in which the mutation is present. And if we weren't unaware of the mutations, if we could not detect in the embryo G452R, we could still decide whether or not it was present based upon the red markers on either side of that. So linked markers is a critical component of single gene analysis. Now, some have wondered whether or not next generation sequencing could supplant the requirement for linked markers. And the answer to that is unfortunately not, no matter how attractive that technology is for PGD and other applications. So just to digress very briefly, next generation sequencing has truly revolutionized the diagnostic aspects of human genetics and medical genetics. So prior to about 2004, 2005, it was necessary to sequence, and both diagnostically as well as to sequence the entire human genome in a very laborious fashion, taking advantage of bacterial and yeast vectors in which snippets of DNA were placed and amplified to produce an amount that would allow us to construct the sequence of DNA. We had to do that de novo because we did not know what the sequence was to begin with. Now that we have the reference sequence, new approaches can be done. And in next generation sequencing, what is being done is that many different fragments can be sequenced concurrently and assembled not simply de novo, but by comparing to the already sequenced reference genome that exists. So this results in the possibility of automation and a much more rapid cost that would exist. So one still has fragments of DNA, but now we can have a targeted DNA because we can recognize this sequence, and we can very quickly analyze for the mutation that would exist. I would remind you that when we assemble the fragments, be that for the entire sequence or simply for a targeted gene in question, the principle remains the same. We look for the last few nucleotides of one fragment corresponding to the first few nucleotides of the next fragment, and we can very quickly make a diagnosis in that case. The basic principle is simply to label each of the nucleotides with a different fluorochrome. The fragments of DNA are placed in capillary tubes. We can do many fragments at the same time. Bioinformatics can then tell us the sequence in question, and this can be done very rapidly in machines that are much smaller than what exists before. So is it perfect, and will it allow us to utilize this simply in order to address the question of allele dropout? And the answer is unfortunately not as attractive as though it is. The reason is that when we do next generation sequencing, we consider success to be about a 98% alignment with the reference genome. In other words, a certain lack of alignment or failure to amplify can be tolerated. Thus, allele dropout could exist. Now, the greater the amount of DNA, the lower the likelihood that this is a serious problem. But we're dealing with small amounts of DNA for PGD. So one obvious choice is to increase the number of cycles, but in doing so, we introduce errors because of the PCR reaction itself. So mutations could be generated that we didn't expect to find, and therefore this does not solve the problem. So basically, we're still required to do some form of a linked analysis, now perhaps using SNPs or other methods in order to do that, but we cannot depend on next generation sequencing to address the problem of allele dropout. Next generation sequencing also has certain other problems. It's not an approach that is applicable for dynamic mutations, and it's difficult to take into account pseudogenes such as for 21-hydroxylase deficiency. A linked approach is still necessary there. So what have we discussed today and what have we concluded? PGD is the prenatal diagnostic approach that is possible if clinical terminations of pregnancies or even embryos to be avoided. That's the only approach. Using array CGH is now recommended for aneuploidy, and the options really should be available whenever we do PGD, whether single gene disorders or aneuploidy itself. PGD certainly will decrease the number of miscarriages, and it increases the time to live birth in couples with translocation carriers. PGD aneuploidy testing, particularly if coupled with cryopreservation of biopsied embryos, can increase the live birth rate without concomitantly increasing the multiple gestations. PGD is the only method that is practical in certain situations, specifically that of non-disclosure for adult onset disorders, Huntington's disease being the disorder that we use for illustrations, or HLA matching, in which we use umbilical cord bud stem cells to treat an older Morgan a child in the same kindred who has a bone marrow disorder. Finally, PGD is highly accurate for single gene disorders, but it does require the use of linked markers. And finally, next generation sequence is an extremely attractive method for PGD as well as other approaches, but it does not obviate the risk of allele dropout, meaning that the linked marker approach still at present is required. I'd like to thank you for allowing me to give this webinar.